Moderators of panel 2 are Dr. Vedant Kabra, surgical oncologist from New Delhi, and Dr. Rangarajan, medical oncologist from Mumbai. The panelists of this session are Dr. Indu, Bansal, radiation oncologist from New Delhi, Dr. Satinder, Kaur, gynec oncologist from New Delhi, Dr. Vivek, Gupta, surgical oncologist from New Delhi, Dr. Vineet, Govinda, Gupta, medical oncologist from New Delhi, Dr. Ashish, Bakshi, medical oncologist from Mumbai, and Dr. Manikandan, Dhanushkodi, medical oncologist from Chennai. Over to Vedant, sir.
Thank you, Kaur. And I'll start straight away with case. Am I audible?
Yeah.
Hello? Yeah. Okay. So the first patient is, in fact, only one patient to discuss. 54-year-old homemaker with a BMI of 32, presents with postmenopausal bleed, hypertensive, diabetic, and has dyslipidemia. MRI shows endometrial lesion of 3.4 centimeters with superficial endometrial invasion. There is no lymph node enlargement and no distinct metastatic disease. Biopsy is grade 2 endometrioid adenocarcinoma. So I would like to know from both the surgeons of panel, Dr. Vivek and Dr. Satinder, what would be your management plan, what is your surgical approach, and the extent of surgery. Dr. Vivek first, and then Dr. Satinder.
Yeah. Hi, good evening, everybody. So as per the description, it seems to be type 1 endometrial carcinoma, or we can say low risk endometrial carcinoma. The plan should obviously surgery first, and it should be minimal invasive surgery, laparoscopic or robotic, whatever it is, and we go for a total laparoscopic hysterectomy with bilateral salivary. Lymph node section means controversy, but in my practice, we are doing lymph node section for these patients as of now because we are not going for sentinel node biopsy. Ideal would be a sentinel node biopsy for this patient.
And Dr. Satinder, have you agreed with this plan? Or you have
so this is stage 1A grade 2 tumor. So as per the MIS criteria, the chances of having lymph node metastasis is less than 1%. So this patient, I think extrafacial hysterectomy with bilateral salpingoophorectomy is the only surgery which is required. Definitely we need to assess the lymph node, and if we find any enlarged lymph nodes, they need to be removed. Sentinel would be an edge over a normal thing. If we have a facility for sentinel lymph node, definitely would be a better choice. But in case you don't have a sentinel lymph node, just these criteria based on MRI findings, less than 50% myometrial invasion, grade 2 tumors, we can also correlate it with cut open second or a rose second intraoperatively and correlate a finding, and then simple extrafacial hysterectomy with bilateral salpingoophorectomy.
This lady has a tumor which is 3.4 centimeters, so it not fit exactly into Mayo criteria.
So initially the criteria was given by Ariani and were from the 33 study, they did include less than 2 centimeters, and those criteria also included. But now the later recommendations, they have removed the size of the criteria. So it's just myometrial invasion less
So
than
this patient comes to you, you omit lymphadenectomy or no?
Yes, I have abdominal lymphadenectomy, but I will definitely examine them, and there are large nodes that remove them. They're not on them.
And would you take help of rosette section on the primary?
So I normally don't do that. If MRI is there and intraoperative, I just cut open the section C, and if it is less than 50%, we don't do a lymph node.
So you would rely on a DNC grade of grade 2, which is reported.
Yes,
Right.
the chances are less. Chances of lymph node method very low in these patients. I'll try that report. It all depends on the pathology. So we usually get the pathology review from our center, and based on that report, and we have seen there is a good correlation pre DNC post-op. So we are actually relying on that thing.
So okay, so we have two surgeons with two different opinions. We would like to do lymphadenectomy, the other one doesn't want to do. But there is definitely a need to identify lymph node metastasis. Although we know that lymphadenectomy is unnecessary in more than 80% of patients. But which one not to do and how not to do is a question that needs a lot of care. And as Dr. Satinder said, MRI, grade of tumor, all size of tumor to some extent. We also know that lymphatic dissemination is generally first site of extrauterine spread. And the moment it goes extrauterine, the prognosis changes. And the lymph node status would also guide adjuvant treatment. So I believe, do you have any experience, anyone of you, with sentinel node or not yet?
So I have done a few cases with million, but that's not a very good option.
That we'll discuss anyway.
Yeah,
right. So,
not with ICD or anything.
But do you think sentinel node is a feasible thing and is an effective option?
Yes, definitely sentinel lymph node is feasible and effective option if you have the facilities of infrared, ICG, and all. Or if as well, actually can get we can use it using isosulfan, which is not easily available. It has a lot of reaction associated with it. Then we can use it at technician 99, but again you get gamma.
Yeah, we'll come to that. We'll come to that. My question was, do you think it is okay,
yes,
Dr. Vivek? So
yeah.
that it should be done ideally if it is possible to do. So this is a very elegant study, FIRES trial, which is a multicentric prospective cohort study from US, including 18 surgeons, and that was a robotic surgery. They did sentinel node detection as we mapping, and then completed systematic lymph node detection, either pelvic only or pelvic plus aortic both. So it started with 85 patients, but ultimately studied on 340 patients, and 293 had lymph node identified. At least one lymph node was identified. So 86% identification of at least one lymph node. And please remember, out of these 18 surgeons, good number of them were actually doing these procedures for the first time or maybe second, third time only. But they were monitored by a more experienced surgeon. A total of 40 lymph nodes were positive. 36 of these had at least one sentinel lymph node mapped. And out of these 36, 35 were positive, giving a very high sensitivity of 97.2% and a negative predictive value of 99.3%. Dr. Vivek, do you think this paper is compelling you to change your practice?
Definitely, because in endometrial carcinoma, the pelvic lymph node detection is overdoing most of the patients. And
So
I'll put this sentinel node biopsy endometrial carcinoma into the forefront.
So if you have a sentinel node equipment tomorrow, and you will use it for the next patient,
especially in a low risk patient, definitely.
Without having any randomized trial for this.
Once this FIRES trial has shown that sentinel lymph node biopsy will not identify metastasis in only 3% of patients with node disease. I think that's a very safe thing to do in metal carcinoma.
You do it. And
Yeah.
which nodes, in your opinion, are sentinel? How would you define sentinel node for endometrium you're operating doing a sentinel node biopsy?
Usually the location of sentinel node I described is the node which is in at the bifurcation of common iliac or a little proximate to it at around the common iliac.
No, but now you're mapping it, so you are using a tracer.
Yeah.
So suppose you are using blue dye or a technetium maintaining with blue dye, then which node would you label as sentinel?
The gold standard is ICD, but if you are using a blue dye, then the node which gets mapped on the blue dye is the sentinel node. That is the node which turns blue on after the injection of the blue dye.
So whichever tracer you're using, if you go to a lymph node, and Dr. Satinder would like to add any other node to it apart from tracer?
So the sentinel, so first drain station is usually a sentinel lymph node, is considered follow the trace uptake, and the first lymph node which we can identify is considered as a sentinel. It can be used using either methods, and it can be anywhere in location. In fact, sentinel lymph node picks up the nodes which are outside a normal lymph node if it is to be bounded also. So that is the advantage. That's why the pickup rate is when higher the lymphadenectomy also.
So lymphadenectomy can be sentinel node.
Yeah, that's right. The point I wanted to make is, if you have a node which is picking up the tracer, apart from that, if you find, as you mentioned also earlier, if you find any large node, you must remove that and test that. And in Indian scenario, we know a lot of PIDs there, so we find quite a large node, so we should remove them as well. Now, Dr. Satinder first and Dr. Vivek, what would be your reference of dye? A combination of the dye or any of the tracers?
So ICG would be my reference, but it definitely needs a near infrared camera.
Your preference is ICG. Dr. Vivek has already mentioned his reference, and we actually have a randomized trial also, which is based the randomized trial, film trial, non-inferiority trial, done in 15 to 17 on 180 patients, and ICG was found superior to blue dye only, identifying at least one sentinel lymph node. It was 96% with ICG and only 74% with blue dye alone. And it also identified more number of bilateral nodes. So we know that if you identify node only on one side, the other side needs to be detected as of today. If you don't find any sentinel node on one side, you need to do lymphadenectomy on that side to have upstay. However, there is criticism that ICG should not be compared with blue dye only. It should be a combination of technetium-99 and blue dye. There are certain studies which have shown that ICG is at least equivalent to a combination or even better than that. So ICG by and large is probably the gold standard, if not in blue dye and technetium-99. What is your preference for injection site, Dr. Vivek?
Although I've only tried in 2 patients, but we don't map because I was only using methane blue. But cervical injection, 3 and 9 o'clock patient.
9 o'clock. And Dr. Satinder?
Cervical. Yes,
it's much easier to do. But the thing is, cervical versus oral, there are some studies which have shown that paraotic mapping is entirely different when you inject into the uterine body, whether subserosal myometrial or hysteroscopic injection, which is peritumoral. And paraotic mapping is almost 40% when you're injecting in uterine body. If you inject deep cervical, it's 17%, and this is a systematic review. And only superficial cervical injection will go 2% times to paraotic. The good part is the slip metastasis from pelvis to paraotic is less than 5%. So even if you don't detect paraotic, most of the time you are likely to be correct. And similar another study was there. However, fire trial did not show any difference in mapping towards paraotic between the two dyes and between the two methods of injection. There is randomized trial going on comparing the two injection sites, and hopefully we'll have a final answer after the results come from this trial. And this is a diagram which shows how to inject. You either inject at 4 corners or inject at 3 and 9 o'clock, which will be injected just submucosally as well as a little deep around 1 centimeter intervally into the stroma. And there are certain nodal basins. One on the left side is the usual one, and Satinder mentioned outside the boundary, and the common side is seen in green on the right side, right picture. So there's another systematic review and analysis which came in 2019. There are several, actually almost every year is one. This is the latest one. They use 6 comparative studies, although all of them were retrospective, but huge database, over 3,500 patients. Nearly 1,250 patients for sentinel lymph node and more than 2,200 for lymph node dissection. And what they found was, very surprisingly, that sentinel lymph node identifying positive node is higher as compared to positive node identification in lymph node dissection. So Satinder, would you highlight why this difference, why we see this difference? Sentinel node biopsy is identifying more number of positive nodes as compared to a proper lymph node dissection.
So the reason is the same, because sentinel would identify the node even outside the boundary of normal lymph node dissection. So in fact, parameter node is the most common, is usually missed because it comes near to inter-iliac lymph node. So when you're doing a parametric lymph node dissection and done an extrafacial hysterectomy, we can miss the parameter node sometimes, which is actually the first drain station. So that is why sentinel lymph nodes picking up things outside better than that.
Right. Would you like to comment on pathological ultrastaging also?
Yeah, definitely. So because in normal, when you're doing lymph node dissection, ultrastaging is not done. So in ultrastaging, basically the microsections are done, and micrometastasis and isolated tumor cells are also identified to be doing ultrastaging. The cuts are variable. Different people, histopathologists, are using different. There is a fixed idea how much cut to be taken. But even cells, limited clusters of cells, isolated tumor cells are less than 200, when those are identified. So we don't know the prognosis of these.
So it's usually cut 3 millimeters and is also subject to immunohistochemistry. So because the number of lymph nodes are low, they can do more intense screening of individual nodes, and that is pathological ultrastaging, and result in finding of more pathological nodes. We really don't know where micrometastatic disease or isolated tumor cells would really impact on prognosis and will change the treatment or not. Only time will tell. And at the same time, this meta-analysis also showed that even if you do only sentinel node dissection, the overall recurrence rate and node recurrence rate is no inferior to lymph node dissection. In fact, it is slightly better, although not statistically significant. So if we take the points from this meta-analysis, the cumulative data definitely supports that the non-inferiority is there for oncological outcome for lymph node recurrence. In fact, I go on to say that sentinel lymph node mapping could be superior to lymph node dissection in terms of detecting positive LV nodes for obvious reasons that we have seen, and this was seen especially in low risk group, which is probably the maximum benefiting group by sentinel lymph node biopsy. But they also going to say that further randomized studies are needed to assess long-term effectiveness, and he's given a call that we must do multi-center large randomized study. They also did some cost-effective analysis. They quoted, actually, I did not do another study, and they found that IgG is best. However, I would like to mention that there is a clash of interest also because some of the authors were received on rating from Striker, and this was Striker's own study as well. This is another abstract which was presented this year in a GEO meeting, which included a good number of high-grade ECs. So most of them were actually high-grade endometrial carcinomas, 3 cancer centers for Toronto. Again, a very great gratification rate of 19%, the bilateral mapping of 77%, and sensitivity of 96% on alpha staging, which again support that sentinel node biopsy is probably going to the standard of care. So the advantages of sentinel node mapping is we avoid lymph node section and small dating form of neural problems and lymphatic problems, lymphedema, lymphoma, lymphocytes. It has excellent sensitivity and negative predictive value, and has better positive node identification rate. Any alternatives? So Dr. Satinder has already mentioned about it, that on a main protocol with low risk patients, we can just avoid having any lymphadenectomy. So if sentinel node mapping is not available, we can follow main protocol. This question already been answered. I just put to conclusions for this part of the panel discussion that sentinel node mapping actually represents one of the most important and innovative changes in surgical treatment of endometrial carcinoma in recent decades, apart from MIS, which is also coming. And ICG as a single tracer appears to the best in sentinel lymph node mapping, bilateral mapping, and very importantly, high BMI individuals where you may not be able to identify the blue dye very easily. Combination of technetium 99 blue dye could probably be equally effective, but needs again additional probe, which is also needed for ICG. Fires and Center trial have shown that there is potential to avoid lymph node dissection in low as well as high risk EC, which is uterine confined disease, and pathological ultrastaging improves metastatic lymph node dissection. NCCN already included sentinel for the first time in 2014, and 2018 said it can be used in uterine confined disease imaging, and if it's found to be uterine confined, intraoperatively as well. However, future we need to see the results of SNET trial. We also need a RCT, which compares the morbidity of both procedures and long-term oncologic outcome. And Bogani has said that presuming that 10% additional positive lymph nodes are found by sentinel node mapping, 500 patients would be needed to demonstrate 10% improvement in survival. So a large number of patients is required and can be done. But we don't know what is the significance of low volume nodal disease. You can compare it with breast. Nothing changes with ITC. Most of the time, you don't change your treatment based on micrometastatic disease also. Molecular classification is something which Dr. Bharath will discuss, and he'll also discuss any surgical modifications according to molecular classification. Thank you very much, all the panelists, and over Dr. Bharath. Thank you.
Good evening. I think my panelists are here. Dr. Indu, Dr. Ashish, Bakshi, Dr. Manikandan. I hope that you're here. I just get yes from them.
Yes.
We are. So I'm just going on directly to the second case, which is a 62-year-old homemaker again admitted with a large volume bleeding in the emergency. She gives a history of spot going on for a long time, more than 8 months. And MRI shows a lesion in the endometrium with involving full thickness of endometrium, low treatment involved. And she had a large latent liquid. She had a biopsy which showed a grade 1 endometrial carcinoma. Long history. She underwent a roboticectomy and BSOB, and she had a private lymph node sampling. This was histopathology report. It was endometrial adenocarcinoma, PT3N1, grade 1 tumor, infiltrating 100% of myometry mass 0. So 1 out of 13 left pelvic lymph nodes was positive. No other node, both the right pelvic node and the operatic node were negative. Now, how do we stratify patients? Now, we know that this patient should go for adjuvant chemotherapy. There's no doubt about this. But we're discussing practice changing paper. So I asked Dr. Indu. We have always been talking of adjuvant therapy. And Portic seems to be the practice changing paper we have to discuss. Now, what is your take on what? Has Portic actually changed therapy, or has just established what has been long thought of as requirement of chemotherapy? What is your opinion?
So Portic definitely showed the addition of radiation in stage 3 cancers definitely improves overall survival as well as improves the failure-free survival. So basically in Portic, they chose 2 arms. One group received radiation therapy plus chemotherapy, and followed by plus radiation, and followed by chemotherapy and cystatin. During radiation, I gave cystatin 50 mg per meter square day 1 day 29, followed by adjuvant chemotherapy, and other group received only radiation. So in this group, they definitely showed that overall there was the high risk group was grade 3 endometrioid carcinoma with deep invasion, lymphovascular invasion, in all cases with clear cell and solids. So definitely there was a 7% improvement in failure overall survival, 7% and failure-free survival also improved. So this is definitely a changing practice paper, and specifically it also showed that there was a significant advantage in serious carcinomas as well as endometrioid carcinomas. So we all know the serous carcinomas otherwise also have poor prognosis. So if you add on radiation to this group, then it definitely leads to improved survival. It did not show much survival advantage in stage 1 or 2, but definitely in stage 3. And
that would be, thank you, Govinda. That would be the next question. Dr. Ashish, do you think that the results?
Interrupt you. So can I request you please make the slides for screen if possible?
Definitely. Sorry. Dr. Ashish, if do you think, do you agree that Protect 3 actually is only for stage 3 patients or stage 1 and stage 2 patients? Do you think they would also come within the Protect ambit, we treat like Protect? If so, which are patients you take? What sort of patients?
The trial did include stage 1 and 2 patients also, as you have shown in your slides. Now, I think the maximum benefit is seen in patients who are stage 3 and serous type. The endometrioid benefit least followed by clear cell, and maximum benefit was in the serous histology. So, I think using the treatment, I would give priority to the histology type as well as the stage of the patient. Usually, in my practice, endometrioid stage 1, we are not giving Protect.
So I'll just quickly ask Manikandan and ask our surgical colleagues after that. Manikandan, would you agree that you would not offer a chemotherapy Protect style to anybody with stage 1 and 2 who have got endometrioid cancer, regardless of grade, regardless of LE, or do you offer for anybody in stage 1 and stage 2 endometrioid type of endometrial carcinoma? Manikandan.
Yes, for if it's endometrioid, only stage 3 would receive we would give chemotherapy. Stage 1 and 2, if it's endometrioid, we would not give chemotherapy because the Protect they separately analyzed stage 2 was there a benefit, there was no benefit in stage 2. Although numerically the numbers are here, it was not statistically significant. So it is either stage 3 or patients with stage 2 serous histology would offer adjuvant chemotherapy.
No, like continue to endometrioid tape is used for
stage 1 to endometrioid, we would not
offer anybody. So I think we have two surgeons. I would ask Dr. Vivek, do you refer anybody with stage 1 to chemotherapy? Because that does happen in practice. We do get rate sometimes there is a reference for chemotherapy Protect style in stage 1 and 2. Are there any patients who, in spite of Protect, you would refer for Protect in stage 1 and 2 endometrioid?
No, sir. In low risk category, don't refer to for chemotherapy.
So stage 1 and 2, what would define as high risk in endometrioid types? Endometrioid
Type 3. Grade 3.
Great. So grade 3. Grade 3 lower uterine segment involved.
Yeah.
Would you refer for chemotherapy?
Yeah. Chemotherapy plus minus vaginal break therapy.
But I ask you stage 2, not stage 3.
Stage 2. Stage 2 lower uterine segment, definitely we refer for chemotherapy.
You would refer chemotherapy in spite of stage 2. Dr. Satinder?
No, I would like get FIF3 done in this patient. So in case the FIF3 is positive on ICE, I would like to refer them for chemotherapy. I had chemotherapy.
So although medical oncologists are not very keen to give chemotherapy for stage 2 endometrioid, you would say that there are some patients who still fall into the ambit of chemotherapy.
Yeah.
I think the decision should be individualized based on other factors, as you have mentioned, there is stratification. So if somebody has a deep myotic invasion, like in this patient, you have shown that almost 100% myometrium is involved. Area is there, and as in the mentioned, if it is mutated, those patients are someone who would consider.
So the next question is back to Dr. Indu, but I want a very short answer. Do you think that every stage 3 and stage 4 really require radiation, or with all evidence there is, we would avoid radiation for stage 3, stage 4 and manage with chemotherapy alone?
Stage 3 and stage 4 definitely radiation. There's no confusion on that.
Okay. The medical oncology colleagues, what do you think from all the review of the rich at Israel? Would you avoid anybody giving anybody radiation?
Can I add something?
Yes, Dr. Yes, you can.
I think a lot of molecular markers are now coming into picture, and if we can do molecular stratification. So basically, I think few simple things can be done. One is P53 and MMR status. We
shall discuss this further because that is a part of the discussion. So the medical oncologist, would you say that if there is a patient who says she will not become radiation at warning, there is such a patient. Do you think that you would be comfortable doing more chemotherapy and avoiding radiation, Dr. Ashish?
Yes, I think based on the geology history, actually for stage 3 and 4, we can avoid the radiation and just give chemotherapy. Only thing is that some small increase risk of recurrence is to anticipate locally. So that has to be explained to the patient. I think overall it won't change much of a difference otherwise in terms of survival.
So pelvic and periodic recurrence, like in GG 258, which included stage 3, 4 patients, even in the age of radiation, the pelvic and periodic recurrence rate was 11% as compared to 20% without addition of radiation. And if we must remember, whenever there is a pelvic recurrence, then the average survival is only 1.5 years, 1.4 years, 1.5 years, which can definitely prolong by addition of radiation. Offers grade 3, 4 toxicities are not.
If I intervene, the point is that radiation produce pelvic recurrences, but the overall survival in the GOG 8 not really show a difference between both arms avoiding radiotherapy. And what about early endometrial carcinoma? We're always giving radiation in endometrial carcinoma when it is indicated, and chemotherapy is substituted for radiation in these tumors. Dr. Indu and Dr. Manikandan?
I don't think so. So this GOE 249 by basically it compared pelvic radiation therapy versus vaginal brachytherapy plus chemotherapy. So in this trial also, the overall survival was better with addition of radiation. and pelvic recurrences were reduced with addition of radiation
It
therapy.
was a superiority study. They wanted to show chemo plus brachy was superior to radiation alone. So it was
And
negative that did not show superiority.
They could not superior. So I think early tumors would still continue to treat with radiotherapy. But over time, this is just a review. There seems to be good amount of evidence, although the radiation has been revealed these, that radiation, chemoradiation, or just chemotherapy all seem to be doing fairly equally in terms of overall survival. And that is something that needs further focus studies. So this.
One comment here. In GOG 249, if you see almost 75% of the patients were endometrioid histology, and very few serous and clear were included. So,
we're discussing only endometrioid here today.
Yeah, so that's the reason why we did not see much benefit with the addition of chemotherapy there.
So we'll just go quickly. A very short question to Dr. Ashish, who's the most senior person on this panel. The question is, how are you comfortable giving chemoradiation and then following it with chemotherapy like the PROTECT, or giving chemotherapy plus radiation, what we can call reverse PROTECT, which is not really evidence-backed very much, and what are the advantages and disadvantages of both? It's a very practical question in clinic.
So I think PROTECT is very much doable in clinical practice. I don't think so because they have just even spread along with radiation. So I don't really foresee a problem there. In case if some patient is elderly or has comorbidity and you are worried about the tolerance of the combined modality treatment, then we can go reverse PROTECT. Second is that I think in stage 3 or 4 disease, if one has to give a combined modality treatment, then one can do that. We give chemotherapy first and follow it up with radiation to minimize those recurrences.
Okay, so the thing is, the tolerance in the GOG 258 only 75%, that is only 3 out of 4 patients who complete 4 adjunct therapies. There are a lot of dose reductions also in the chemotherapy when it's followed by RT, and that may be one of the reasons why the arm would be was inferior outcome in the RT arm. Now we'll go to the second part of the panel discussion. What is the requisite pathology work that you ask apart from routine histopathology? What are the additional tests that we require? Dr. Manikandan?
We routinely do ERP also. And if we means the histology is unclear, then we would do a P50 also to see whether it is serious histology. And if it is metastatic, we do MSI also.
Okay. Dr. Vineet Gupta, you here? I'm sorry, I didn't realize. Dr. Vineet, what are the, all the tests that you do as a quiz pathology workup? Addition what Dr. Manikandan has added?
So no, we won't do this. In the advanced setting, this can might do intention sensor, but the first line you won't do it.
You do not want. In how the patient completed chemoradiation, both sides of chemotherapy, like PROTECT, developed recurrence 17 months with abdominal pain, and she had HC, which was a large priority. No, this was, I'm not thinking with all this. What we did was we did DRR, which was positive, 2 was negative, and SI, which was also all 4 rates were retained. So how do you treat the patient at this point, Dr. Vineet? Would go on the basis of ERPR, or would go clinically and treat with chemotherapy, or do you take some molecular pathology?
So yeah, I would since the patient already been exposed to frontline chemotherapy, I would always go for extended sequencing in this scenario. Because we know that some center patient like the case like very poorly mutated, they may not show the MRI, but still they have very high mutant burden instead of chemotherapy. So that would be NGS definitely important patients in the second line.
You would not just suppose the patient has some of the ER and ER positive tumor, you would not stop evaluating that point of time, would still consider going on with NGS?
Yes, absolutely. So of course, ERPR is important because some of these patients are sensitive to hormone therapy, but we know that hormone therapy will not control the tumor forever. So it is always a priority to do sequencing this.
You would do sequencing. Dr. Manikandan, do you do sequencing and you work in a sort of community hospital setting, which these Vora patients? So what do you do in this situation?
So our frontline treatment is chemotherapy, that is aclaxababatin. If it is very low burden disease, the patient is very old, it is endometrial histology in low grade, we prefer hormone therapy, progesterone alone or progesterone alternating with tamoxifen. And for serious histology, we do IC50 also. Currently, we are not offered target therapy or immunotherapy in this setting.
Okay. Dr. Ashish. Dr. Ashish, for a patient who is symptomatic who comes with a large node, even if the patient ERPR, would you say that you would offer hormone therapy or would you offer chemotherapy?
I think if the patient has bulky disease, obstructive symptoms, very symptomatic, then I would prefer chemotherapy in order to get a quick response rather than hormone therapy. In those patients who have small volume disease, symptomatic, then in those group of patients, one can consider hormone therapy if the patient is ERPR also.
Dr. Satinder, would you want to do this pre-op? Would you like to do this information pre-op? Would change your management, or in the post-op setting, would you change your management for early endometrioid?
So definitely molecular staging, this classification is going to change the treatment of endometrial cancers from the very beginning. So for early, like there is a whole mutant type, we can actually avoid the whole controversy since general lymph node go out. We base our management on basis of this molecular classification. Lymph nodes can be avoided in whole mutant types which were very good prognosis, and those which were bad prognosis, you have to do a complete lymph node direction. For example, in this case, thyroid lymph node dissection was not done initially, sampling was done. If I knew the molecular state initially, I would have done a complete thyroid lymph node and the recurrence would not have isolated thyroid lymph node recurrence would not have happened. So, and later on, if you know that it is a high-grade thing, it is peaked, it's mutated, or it's copying by high, so probably you go edge for chemotherapy rather than opting for a hormonal therapy in this case also.
So she was actually grade 1 with a node at baseline. So I think that's sort of a clue that it's not a whole mutate type.
Yeah, but so that is still the parotid lymph nodes were still a parotid in spite of a node being there on the MRI also. Complete parotid lymph node direction was not done in this case. It should have been done. The disease was reaching up to the ROSA. So it was stage 3, indicating towards stage 3 initially. So It will just add a benefit to it, and we be better able to do surgical, better able to decide the surgeries and adjuvant therapy if initially the molecular classification of the patient based on the ENC.
So take home is that both in terms of chemotherapy and in terms of stratifying for chemotherapy and in terms of stratifying for infiltration, extent to surgery, the molecular classification will be very useful in the coming era. I think we've discussed a little bit. This patient received 4 cycles of dilated liposomal doxorubicin and carboplatin, and she opted stop chemotherapy because of side effects. She's
Yeah, something. This patient had isolated period lymph node recurrence, didn't have any other reason. So was any radiation consultation for
actually you can see the first thing she had value RE to the right nodal mass, and then she received 4 cycles.
You didn't mention that.
It's on the side. It's on the side for want of time. So this patient has actually finished the chemotherapy. Would put her hormone maintenance now, or you would wait for her to progress further? Dr. Vineet.
Yeah, I would put her on hormone therapy at this point.
What sort of hormone therapy you use as maintenance? What sort of hormone therapy?
So I'm mainly using aromatase inhibitor in these patients. Some patients we put on the
You put her on aromatase inhibitor. Manikandan, as a maintenance, what would you using the aromatase inhibitor regarding the activity of the aromatase inhibitor?
I think we would use progesterone and specific for MGOD, but I don't think we have randomized comparisons between what age to use as a maintenance.
But if
you have to conclude that you have to.
Yes, yes, sir, I'm almost done. I'm actually done. So any final words, immunotherapy from Dr. Ashish, and then we can conclude.
No more from panel.
Yes.
You conclude yourself.
The only other important trial that's come is the keynote 156, which took MSI not high patients, that is deficient NMR patients, pembrolizumab, which had a good overall response rate, which can be used in patients who are not MSI high. So that I think we conclude panel.
Thank you, sir.
And I thank all panelists for active participation. Thank Dr. Amish.
Thank you very much, Bharath and Dr. Vedant. Excellent job. I think we can say this because Vedant has already asked how many centers routinely do lymph node mapping. Dr. Rajesh Jindal has a question that will pre-op can help to decide about the lymphadenectomy. Maybe Vedant, you have asked many questions. You can answer this question. Do we have
So,
Vedant?
yeah, I'm there. I don't think PET-CT will help to decide completely about lymphadenectomy. Yes, it will guide us if there is a node in some area which is lighting up. Even if it doesn't take up the tracer, we should remove it while doing sentinel node biopsy. But then it will not, if there is no uptake on PET-CT and we don't do lymphadenectomy in spite of this feature, is not the right thing.
Okay, so just maybe we can ask this question to Ashish. Ashish, what should be the choice of investigation pre-op, CT or MI? And maybe you can ask Dr. Satinder to confirm. I would prefer MI. You would prefer MI. Okay, Dr. Satinder, what would you prefer?
So ideally, as we go only ultrasound sufficient because we want to see, have to just see the biometric invasion. We can see the TS as well. MRI is basically done. People who basically decide the lymph node extent of lymph node dissection based on biometric invasion, they do an MRI. Otherwise, if you want to just see the lymph nodes, whether enlarged or extra uterine disease which is detected on ultrasound, then a CT is a better modality. For biometric invasion, MRI is a better modality.
Right. I think what Dr. Hemant sir has said was already addressed during panel discussion that since the pelvic lymph node was positive, why was RPLND not done? Sir, would you do RPLND in all such cases? Maybe coming from you would be welcome. Dr. Dugam, sir.
Can I take he not there?
Yes, Vedant,
so
please.
it wasn't done only for low risk patients, for high risk patients, and for those where the sentinel node was positive and was located in parotic area, it was done. So for low risk patients, it was not done even if the pelvic nodes were positive on sentinel node.
Right.
The recommendation is that for pelvic node positive, you need to do a complete periodic lymphadenectomy.
Okay, so where you routinely do that, sir. This question is already addressed in a big debate way. So, great, Dr. Ilish, stage 1, grade 3 endometrioid, chemo or chemo, and role of molecular markers. I think the role of molecular markers can go back to previous years. The role of molecular markers, and Dr. Satinder has said that very clearly. I agree with her. Vedant and Vivek, would you do molecular marker study in all patients often pre-op, and would your treatment change based on that? That was the whole premise of PROMIS study.
Not yet.
Not yet. You would not do. Okay, Vivek, do you do in any of the patient molecular markers upfront?
No, for surgery, no.
Togam sir, and Dr. Satinder said, if whole mutated upfront and whole lymph node, would you bother to do any sentinel lymph node observations?
Well, frankly, I don't do sentinel node biopsies at all.
Okay, can you move to the next question, please? Yes, Dr. Seema Singhal is asking, stage 2 is categorized as high risk as per ESMO criteria. Maybe Vedant, you want to take this?
Sorry, Amish, I didn't hear what you were asking.
Stage 2 is categorized as high risk as per ESMO criteria. Question from Dr. Seema Singhal.
Yeah, I agree.
Okay. In chat box, somebody saying no. Maybe the answer to the same question. Okay. Dr. Rajesh will say, I think stage 3 brachy plus chemo versus radiation plus chemotherapy is already been addressed. Can you move to next question? Dr. Arun Chandrasekhar says stage 1B grade 3 has a category 2 recommendation for chemotherapy as per NCCN. Would you use chemo in this setting? Dr. Manikandan, would you use chemo in the setting?
Manikandan actually answered saying no during the panel.
Bharath, would you use?
I would not use for 1B grade 3 at this point. And Manikandan also said he would not use. But in patients who have low uterine segment, that's stage 2, not grade 3. So like a showman invasion, that is a grade stage 2, B2, we sometimes use.
So, Bharath, let me ask you the same question. P53 mutant. Would you give chemotherapy in your OP clinic outside the setting of evidence-based?
Sir, as of now, we are not really doing the P53, are not looking at it. But
Patient comes with P53.
Then yes, I would do it. Because once you have identified a report, identify a high-risk patient, the poorest group of all the 490, yes, I might consider for sites of chemotherapy after, the Pendari.
Right. So, Dr. Arun, maybe you have got your answer. Next question. From Dr. Ajay Rao, in stage 2 endometrioid carcinoma, cervical stroma involved, don't you think chemo has to be added to radiation in stage 2? Dr. Indu, let me ask you, in stage 2 endometrioid cervical stroma is involved, you are planning for radiation. Would you involve your medical oncology colleague in such situation?
Normally, no.
Dr. Ashish, this patient comes before radiation to you. Would you tell patient to come back to you after radiation?
I would, yeah.
You would. Okay. So this is sort of a gray zone. Radiation oncologist saying no, medical oncologist saying yes.
I will definitely refer them for opinion.
Okay.
Can I add something?
Yes, Bharath. Yes, Bharath.
The surgeons generally don't prefer to give chemotherapy when there is.
Okay. Right. So time up, and thank you so much for the audience for such interactive session. I have not seen such interactive chats so far. Thank you so much. And with that, we move to panel 3.